Good morning. My name is Sanjeev Chopra, and sitting on my left is Dr. Tom Lamont. And on behalf of our distinguished faculty, it is my distinct privilege to welcome all of you to the GI Hepatology Academy. I think at times like this, it is appropriate for us to take a minute and reflect on our profession. Justice Louis Brandeis once said, there are three attributes of a profession. The first is that there is a specialized body of knowledge known primarily to its practitioners. The second attribute is that it is performed more for the benefit of society than for personal gain. And the third attribute is that society in turn confers upon the profession great autonomy. So we make the rules in gastroenterology and hepatology about how many years of training, how many years of fellowship. A colleague of mine and a mentor of many of us at Harvard Medical School, Dr. Dan Federman, once added a fourth attribute. He said in the medical profession, there has to be an encompassing moral imperative. And I've taken the liberty of adding a fifth attribute. And the fifth attribute is learning. Learning is a lifelong privilege. Pursue it with passion and zeal, and you'll see the wonder fill your world. Your very presence here is a declaration of your intent to learn, to get a few nuggets of knowledge from perhaps each of the talks, so that at the end of the day, you're practicing state-of-the-art medicine and you're doing the best for your patients. So in reality, this course is a celebration of all the good work you do. I'm delighted all of you have joined us this morning. And I'd like to now, at this stage, turn the podium over to Dr. Tom Lamont.
Good morning. My name is Dr. Tom Lamont, and you are tuned into the live session called Nonalcoholic Steatohepatitis, an Emerging Epidemic, with Dr. Sanjeev Chopra. Dr. Chopra is Professor of Medicine and Faculty Dean for Continuing Medical Education at Harvard Medical School. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Sanjeev?
Yeah, you want me to start?
Please.
Okay. So I'm going to give the first talk, and this talk is entitled Nonalcoholic Steatohepatitis, the Emerging Epidemic. I have no relevant financial relationships with commercial entities pertaining to this talk. Now let's start by first defining nonalcoholic steatohepatitis, or NASH. Nonalcoholic steatohepatitis is the term used to describe the distinct clinical entity in which patients lack a history of significant alcohol consumption and yet have liver biopsy findings that are indistinguishable from the morphological features one sees in alcoholic hepatitis. I'd like you to take a moment to reflect on this definition. And you'll probably note that there are two potential problems with this definition. The first one is, how good are we at taking a history of alcohol consumption from our patients? How truthful are our patients in telling us about how much alcohol they drink? And the second potential and significant problem here is that we'd have to do a liver biopsy in all the patients in order to make this definitive diagnosis. And I'm going to come back to the role of the liver biopsy and possible alternative modalities in order to assess the degree of severity in patients with presumed non-alcoholic fatty liver disease. Now, the correct rubric is actually NAFLD, or non-alcoholic fatty liver disease, because only a subset of patients have non-alcoholic steatohepatitis. A lot of patients simply have macrovesicular fatty infiltration of the liver, steatosis. And these patients actually have a better prognosis. In contrast, patients with NASH, in addition to having macrovesicular fatty infiltration of the liver, also have ballooning degeneration of hepatocytes. They may have polymorphonuclear infiltration, and they may or may not have Mallory hyaline bodies and may or may not have significant fibrosis. And a small subset of these patients with NASH, estimated to be 15 to 20%, go on to develop more progressive liver disease with complete architectural distortion of the liver and islands of hepatocytes totally circumscribed by connective tissue, which is, of course, what we term cirrhosis. And it's only when the patients have evolved into cirrhosis that they are at risk for liver failure and the development of primary hepatocellular carcinoma. So the criteria for the diagnosis of NASH is that a liver biopsy shows macrovesicular fatty change with inflammation, with or without Mallory hyaline bodies, fibrosis, or cirrhosis. And there's convincing evidence of negligible alcohol consumption, which is defined as less than 10 grams a day for women and less than 20 grams a day of alcohol for men. Most of these patients come to light because the primary care physician has noted that they have an elevated ALT, or that they have hepatomegaly, or that they have peripheral stigmata of chronic liver disease such as Palmer erythema and spider nevi. And often the first test that's performed is a liver ultrasound. And what it often shows is that the liver is slightly enlarged and it is bright and echogenic, consistent with fatty infiltration of the liver. Now, the appropriate ultrasound report is not the first half of what you see on this slide, which states the liver is enlarged, it is diffusely echogenic, consistent with fat infiltration of the liver. What needs to be added, and in our hospital at the Beth Israel Deaconess Medical Center, the ultrasound radiologists have been adding this rider for the last several years. And the rider states other forms of liver disease and more advanced liver disease, including early cirrhosis, cannot be excluded by this study. So in fact, that patient with fatty infiltration of the liver and mild hepatomegaly may also have hemochromatosis or Wilson's disease or alpha-1 antitrypsin deficiency or granulomas in the liver. And that patient may already have established cirrhosis and even mild portal hypertension. The point I'm making here is that radiology, ultrasound, CT, and MRI can make the diagnosis of cirrhosis only in the instances where the liver is small, nodular, the spleen is big, enlarged, there are prominent collaterals, we call them varices, in the hilum of the spleen, in the porta hepatis, and there's ascites. But if you don't see that, you can't be certain that your patient does not have cirrhosis. This begs the question, what's the role of liver biopsy? And I'm going to come back to that in a few minutes. Now, if you do a biopsy, very often you see macrovesicular steatosis as shown in this H&E of a liver biopsy, a percutaneous needle biopsy of the liver. Sometimes, in addition, you see sinusoidal infiltration with neutrophils and ballooning degeneration of hepatocytes. So now this patient doesn't simply have fat in the liver. This patient has steatohepatitis, and this is the entity of non-alcoholic steatohepatitis or NASH. Here on a trichrome stain, one sees the chicken via, pericellular fibrosis. This patient is already advancing towards more substantial and significant liver disease. Here in the center of the field, one sees a ballooned hepatocyte with eosinophilic, ropey, altered cytoskeleton. This is referred to as Mallory hyaline bodies. And this is the most advanced form of liver disease. In this patient, the histological features of fatty infiltration, Mallory hyaline bodies, ballooning degeneration have all disappeared. And what you see are islands of hepatocytes totally circumscribed by connective tissue. This patient has cirrhosis of the liver. This is actually a patient of mine, 55-year-old principal from one of the schools in the Boston area, and he had no symptoms. He had a normal ALT, AST, protime, albumin, alkaline phosphatase, and bilirubin, and presented while on vacation in Puerto Rico with a life-threatening varicose bleed. The only abnormality in his entire laboratory workup was a platelet count of 100,000. He had a portal vein that was patent by ultrasound, and he was negative for hepatitis B and C serologies. He had no evidence of hemochromatosis, other causes of liver disease, was mildly obese, had type 2 diabetes, and had high lipids. So this is a patient in the past we would have called having cryptogenic cirrhosis. But what he had in reality was burnt out NASH with cirrhosis of the liver. And some studies suggest that roughly 3/4, 75% of the patients we have in the past labeled as cryptogenic cirrhosis in reality have burnt out NASH. Here's a sort of brief summary about this. 74% of 70 consecutive patients with cryptogenic cirrhosis had obesity or diabetes. And this percentage is similar to the prevalence of obesity and or diabetes noted in 50 consecutive patients with biopsy-proven NASH. Even more compelling is the fact that some of these patients with end-stage cirrhosis and complications wind up getting a liver transplantation. What happens after the liver transplant? They still have diabetes, they still have obesity, they still have hyperlipidemia, and they get recurrence of the liver disease. And now when you go and biopsy them, they have the histological features of NASH. They have Maury hyaline bodies, fatty infiltration, polymorphonuclear infiltration. Let's talk briefly about the epidemiology of NAFLD. The estimate is that we have 40 million Americans with NAFLD. Let me put that in perspective. We have at a maximum 4 million Americans with chronic hepatitis C virus infection. Of these 40 million Americans with NAFLD, 5 million are cirrhotic. The estimate for the 4 million with chronic hepatitis C is that 500,000 are cirrhotic. So from NAFLD, we have 10 times as many patients with cirrhosis as with chronic hepatitis C virus infection. Chronic hepatitis C virus infection and end-stage liver disease is currently the dominant indication for liver transplantation in our country. NASH with cirrhosis is the third leading indication for liver transplantation in our country. And by many estimates, in the next 10 years, it will become the dominant indication for liver transplantation in our country. NASH, cirrhosis, and liver failure. The majority of patients with NASH have metabolic syndrome. And here's a very sobering statistic. Over the age of 60 years in our country, 40% of patients or individuals have metabolic syndrome. So NAFLD is indeed part of what we've referred to as the metabolic syndrome, sometimes called Syndrome X. And my plea to you is that when you see a patient with obesity, with high insulin levels, with insulin resistance, with high lipids, with hypertension and diabetes, also ask yourself the question, does my patient have liver disease? And if so, what stage of liver disease does my patient have? Do I need to do a liver biopsy? Do I need to vaccinate for hepatitis A and B? What should I be doing in terms of weight loss if they are overweight? And we'll come back to the topic of coffee. Should I actually be recommending coffee? Because many studies show that coffee is hepatoprotective. Now, what about the natural history of NASH? And what about patients with NASH who actually have a normal ALT? We tend to focus on patients and think about liver disease when their ALT is elevated. We then repeat it. If it's elevated, we often repeat it a third time. And if that shows that the ALT is elevated, these patients are referred to as having persistently abnormal ALT. Well, in this study published a few years ago in Hepatology, they excluded other causes of liver disorders and then biopsied patients, even those with normal ALT, and compared them with patients who had an elevated ALT. And you can see that fibrosis stage 2 or greater was present in about a fifth of the patients with a persistently normal ALT and in about a third of the patients with an increased ALT. The p-value is not significant. There are a couple of studies now that have been published in hepatology suggesting that we need to lower the upper limit of ALT. Currently, in most of our labs, it's 40 or 42. It really needs to be about 29 in men and about 22 or 24 in women. None of the official societies have embraced this, but I think for me, the message is when I see a patient with presumed liver disease and their ALT is normal, but it's in the upper range of normal at 36 or 37, I don't consider that normal. If they're 20 or 22 or 18 or 19, then it's perfectly normal and they're not going to have significant liver disease on biopsy. It's also important to mention that there are other conditions where you see the exact histological diagnosis that is seen in patients with biopsy-proven NASH. A variety of drugs or toxins, abdominal surgery, a number of metabolic disorders, and then some rare and miscellaneous conditions. One disorder that is critical to exclude in young individuals with a histological diagnosis that looks like NASH, sometimes the pathologist will actually say these features are consistent with a toxic metabolic etiology. And then it's our job as clinicians to figure out which toxin. Is it alcohol? Is it one of a variety of medications? Which metabolic disorder? And of course, most often that's metabolic syndrome, but it can, on rare occasions, be Wilson's disease or A-beta-lipoproteinemia. Here's a patient who was diagnosed as having features consistent with toxic metabolic etiology. He was 34 years of age. There was no diagnosis previously, and because his liver biopsy showed toxic metabolic features, we looked at his eyes more carefully. And lo and behold, there's this subtle deposition of golden brown pigment in the Descemet's membrane. These are the characteristic Kaiser-Fleischer rings. Now, you and I can miss this, and if you suspect Wilson's disease, it behooves all of us to send the patient to an ophthalmologist to do a slit lamp examination to rule out bilateral KF rings. The combination of bilateral Kaiser-Fleischer rings and a low serum ceruloplasmin clinches the diagnosis of Wilson's disease. These patients are then put on a low copper diet and they're asked to take D-penicillamine, and then of course a very important thing, family members need to be screened. This slide shows the common drugs that are associated with NASH: glucocorticoids, synthetic estrogens, tamoxifen, perihexylene maleate, amiodarone, isoniazid, and millions of our patients are taking one or more of these medications. What about the natural history of NASH and progression to cirrhosis? I think it's appropriate to compare it with alcoholic hepatitis. And if you look at alcoholic hepatitis, progression to cirrhosis occurs in up to 50% of patients, and the 10-year survival is abysmal at 20%. In contrast, in patients with NASH, progression to cirrhosis occurs in about 15 to 20% of patients, and the survival at 10 years is far better at 60%. What are the clinical features of NASH? Most patients are asymptomatic, and the rest have very nonspecific symptoms such as fatigue or a little bit of right upper quadrant discomfort or pain. And what about the laboratory features? I showed you earlier that the ALT can in fact be normal and patients can have significant fibrosis. Majority of the patients in studies have been noted to have an ALT and AST 2 to 4-fold the upper limit of normal. The alkaline phosphatase is mildly elevated in a third of patients. The albumin, prothrombin, bilirubin are normal unless the patient develops decompensated cirrhosis. Of interest, the serum ferritin is elevated in half the patients. It's important to realize that the ferritin is an acute phase reactant, and it doesn't signify that these patients have hemochromatosis. The overwhelming majority of them do not have significant iron deposition in the liver. The majority have mild increase in iron deposition in the liver. What about the role of a liver biopsy? The pros, as we've discussed, is that NASH is a histological diagnosis. The patient may be asymptomatic. He or she may have a pretty normal looking liver function profile and yet have advanced liver disease. Poor correlation between lab findings and histological severity. And biopsy results would change management in the 10 or 15% of patients that turn out to have cirrhosis. The moment we diagnose cirrhosis, reflexly, we have to screen for esophageal varices. We have to survey on a regular basis for primary hepatocellular carcinoma. The cons, there's a small but finite risk of complications, even with ultrasound marking. Biopsy results may not change management. In the patients who are not cirrhotic, we'll be telling them, you need to lose weight, control your diabetes, get vaccinated for hepatitis A and B if need be. And that's going to be in the majority of patients. And also importantly, we don't have the manpower to do liver biopsies in 40 million estimated Americans with non-alcoholic fatty liver disease. So here's what I recommend at the moment for patients with suspected NASH. I think it's reasonable to perform a liver biopsy if any of the following are present. The patient has peripheral stigmata of chronic liver disease. Patient has striking bilateral palmoerythema, several spider nevi, or the patient has splenomegaly, or the patient has a low white count, platelet count, red count, if they have an elevated ferritin. And the last bullet on this slide is actually pretty startling. It's a study from Mayo Clinic. They took patients with suspected NASH who had diabetes and or significant obesity, were over 45 years of age, and had an elevated ALT. That's a lot of our patients out there. And they did a liver biopsy on every such patient in that study. 60%, let me repeat that, 60% had bridging fibrosis or cirrhosis of the liver. And if the AST was higher than the ALT, 70% had cirrhosis of the liver. This is an observation we've also made in hepatitis C patients. When you follow patients with the majority of liver disorders, other than alcoholic liver disease, the ALT is higher than the AST. If you see that ratio flip, and now the AST is higher than the ALT, it's very likely your patient has developed cirrhosis of the liver. Are there alternatives to liver biopsy? One of the important things about liver biopsy is there can be significant sampling. As shown here, the liver biopsy needle traverses this part of the liver. You see the blue trichrome, fibrosis on trichrome stain, and the pathologist says fibrosis area 65%. This patient has advanced fibrosis of the liver. During the same procedure, the hepatologist, through the same entry site, angles the needle differently. And now, lo and behold, there's very little blue, very little fibrosis. The fibrosis area is only 15%. So over the last 3 or 4 decades, we've said liver biopsy is the gold standard for assessing histological severity. It really isn't. There's significant sampling. Are there alternative tests? There's a blood test. This is one of them. It's called Fibro test or Fibersure, and you can see it looks at a number of modalities, but look at the correct identification of histological severity. Roughly half the patients. It's like tossing a coin. They call it Fibersure. I call it I'm not so sure. But there is another modality, and this is called a Fibro Scan. And we at the Beth Israel Deaconess Medical Center in our liver unit, thanks to the leadership of Dr. Nid Aftal and Detlef Schupan, have been studying and doing research on the clinical utility of the Fibro Scan. This is non-fasting. The examination takes less than 5 minutes. Median value of successful acquisitions is tabulated. And look at the Fibro Scan. It's looking at 1/500th of the liver volume. A liver biopsy looks at 1/50,000th of the liver volume. So it's also called hepatic elastography. It's a rapid, non-invasive measure of hepatic stiffness. and hepatic stiffness correlates with fibrosis of the liver. So again, to reiterate, liver biopsy samples only 1/50,000th of the whole liver. A Fibro Scan samples 1/500th of the whole liver. What's the likely future scenario? We'll have patients with suspected liver disease. We may do certain biomarkers, but more importantly, we'll be doing the Fibro Scan. We're waiting for FDA approval. It should happen shortly. The Fibro Scan is approved in many countries around the world. And then the reading will come back. Low likelihood of fibrosis. There is no need to do a liver biopsy. You may treat the patient or simply follow the patient. On the extreme right is that the Fibro Scan and perhaps the biomarkers will suggest a very high likelihood of fibrosis. Again, we can be pretty confident that these patients will turn out to have cirrhosis of the liver, and there is no need to do a liver biopsy. Screen them for primary liver cancer, screen them for varices, screen the family if it's important to do so, and treat the patient if it's a treatable condition. It's the gray zone in the middle where we may still need to do a liver biopsy. By some estimates, the use of the Fibro Scan will obviate the need for a liver biopsy in more than half the patients we are currently performing liver biopsies on. So stay tuned. I think this is going to be a major and imminent advance in hepatology. Now, what about Fibro Scan, and can you actually do it in patients with non-alcoholic fatty liver disease? What if they are markedly obese and it's going to be difficult to wedge the Fibro Scan between the ribs? This study in hepatology a few years ago concluded that the Fibro Scan is accurate in most patients with NAFLD, not all, maybe 10-20% of patients we may not get an accurate reading. It has high negative predictive value and modest positive predictive value. The Fibro Scan is useful as a screening test to exclude advanced fibrosis. What about progression? The initial biopsy results may be useful. If they have fat alone, progression to cirrhosis occurs in only 5% of patients. But if they have NASH, ballooning degeneration, Mallory-Highline, and even a little bit of fibrosis, progression to cirrhosis occurs in about 20 to 25% of patients. So currently, in patients of mine whose initial biopsy has only shown fat, I tend not to repeat the liver biopsy. But those who've had biopsy-proven NASH, I tend to bring them back every 3 to 5 years and repeat the liver biopsy to see if there's been significant progression and perhaps even progression to cirrhosis. Remember again, with the availability in the near future for the Fibro Scan, we will not need to repeat many more liver biopsies. What's the pathogenesis of NASH? There's clearly perturbation of fatty acid processing. There's insulin resistance. There's lipid peroxidation and oxidative stress. The oxidative stressors include hepatic iron, intestinal bacteria, leptin, and states characterized by antioxidant deficiencies. This is actually a very interesting study in which this young investigator looked at liver biopsies of patients with NASH. He saw there was increased iron. He actually calculated the hepatic iron concentration index, and it was not in the range that we see in hemochromatosis. He looked for the genetic mutation for hemochromatosis, blood test, looking for C282Y and 863D mutations. None of the patients with NASH had it. He then performed a phlebotomy. He did a 1-unit phlebotomy roughly every 2 weeks, and the average patient with NASH was adequately de-ironed with 4 to 6 units of phlebotomy. And what he noted was that there was normalization of the ALT and AST. There was improvement in markers of insulin resistance. And in fact, liver biopsy showed improved histology, the repeat liver biopsy. It's a brief study. We don't need to embrace phlebotomy at this stage, but it's something we should keep in mind as a potential treatment down the road for patients with significant biopsy-proven NASH. So the pathogenesis of NAFLD and NASH is summarized on this slide, the so-called two-hit hypothesis. In the first hit, there is increased fat, And in the second hit, there is more going on. There's increased TNF-alpha, there's lipid peroxidation, there's oxidative stress, there's increased iron. What's not shown on this slide is that patients with aggressive NASH also have low levels of plasma adiponectin. So let me repeat that. Low levels of plasma adiponectin are linked with aggressive NASH. I'm going to come back to this when I briefly talk about the potential hepatoprotective role of coffee. So what's the prevention and treatment of NASH? Clearly, prevention of obesity and metabolic syndrome. Many of us as physicians should take a personal responsibility and role and teach in schools, in middle school, about the importance of not getting our young kids, our future leaders, to become overweight, because then they'll be at risk for this very important liver disorder. Clearly, treatment of the metabolic syndrome, bariatric surgery, if appropriate. And then, do we really tell our patients to drink coffee? I'll come back to that. Here's one modality that has been tried, a publication in Gastroenterology in 2008, pioglitazone therapy over a 12-month period. Now, this was looking at non-diabetic NASH patients. Remember, not everyone has diabetes. Not everyone has the metabolic syndrome. So these were non-diabetic NASH patients, biopsy proven. It resulted in improvement in biochemical, metabolic, and histological parameters. But what happens if you stop the pioglitazone? Everything reverts back to being abnormal. And one of the side effects of the glitazones is that patients tend to gain weight. And when you stop the glitazone, they hang on to that increased weight. Weight loss is clearly beneficial. In this study published in Hepatology 4 years ago, a 9% or greater weight loss resulted in biochemical improvement, histological improvement, improvement in insulin resistance, and adiponectin levels rose. Following bariatric surgery, for those patients who have diabetes and obesity and need bariatric surgery, hepatic fibrosis can improve or can actually be reversed in about 2/3 of the patients. A caveat, if the weight loss is profound and rapid, the liver disease can actually worsen. What about vitamin D? This is a study published by Arun Sunyal and colleagues from Virginia in the New England Journal of Medicine a couple of years ago. They had 247 adults with NASH, again without diabetes, randomly assigned to pioglitazone, vitamin E, or placebo. The vitamin E group had significant improvement in global histology. But look at the figures in parentheses. Less than half the patients on vitamin E improved, and about 1/5 of patients on placebo improved. And there are lots of concerns regarding vitamin E and increased cardiovascular mortality. So many of us hepatologists do not recommend vitamin E at this point in time. If the patient is already on 400 international units, I let them stay on it. I make sure they don't have advanced cardiovascular disease, but I do not prescribe 800 international units of vitamin E. Here's a little quiz. Who is this person and how old was he when he died? And how many cups of coffee did he drink every day? I think if you don't know the answer, at least for question 2, you're going to be pretty startled. So this is Voltaire, the French philosopher, who lived to the ripe old age of 83 years when life expectancy was around 45. And how many cups of coffee did he drink? Astounding 50 to 72 cups of coffee a day. I'm often asked, what was the size of the cups of coffee? And I said, how does it matter? Even if they were this big, 72 adds up to a lot. Jefferson, by the way, also lived to 83 and drank a lot of coffee. So what's the coffee connection? We really don't know the mechanism, but coffee contains more than 1,000 constituents: caffeine, cafestrol, and caviol. 3 of the constituents are protective in experimental studies of liver injury. You produce liver injury in an animal model. You now repeat the experiment and you treat the animal with cafestrol or caviol. It totally abrogates the liver injury. Coffee is also very rich in antioxidants, one called chlorogenic acid. It's also insulin sensitizing, and indeed, it has protective effects in type 2 diabetes. And coffee drinkers have three things that we've found, and this is a study from the Joslin and the Beth Israel Deaconess Medical Center, published a couple of years ago. Coffee drinkers have lower levels of TNF-alpha. Coffee drinkers have lower levels of CRP, C-reactive protein, and coffee drinkers have higher levels of plasma adiponectin. It's been estimated that more than 1 billion people in the world have chronic liver disease, and this study published in Gastroenterology demonstrated that consuming 2 cups of coffee per day, and this has to be regular coffee, not decaf, reduces hospitalization rate and mortality from chronic liver disease by more than 50%. I have in your bibliography at least 12 references on coffee and liver disease, with the first one coming from Art Klatsky back in 1992. And you'll notice here that reference 16 looks at the association of coffee and caffeine specifically in patients with non-alcoholic fatty liver disease. And what they showed was that coffee drinkers had less hepatic fibrosis. Independent predictor of decreased fibrosis was coffee consumption. None of these studies have been sponsored by Starbucks or Dunkin' Donuts. This is the most astounding study, which was published in the New England Journal of Medicine less than a year ago, and it showed it was a large prospective study, and it showed that coffee drinkers had lower total and all-cause specific mortality. Just a word about the legend of coffee. It originated in Ethiopia in a village by the name of Kaffa. There was a shepherd by the name of Kaldi. He would take his sheep for pasture. He noticed in one particular pasture they were very frisky and animated, and the sheep were consuming these berries. So he made a brew out of it and he enjoyed it. There was a monastery nearby, and a monk used to walk by, and he scolded Kaldi. He said, "Kaldi, you have partaken of the devil's fruit." Kaldi ignored him. After a while, the monk said, "Let me taste it." And he was able to keep up for the late night prayers. It then spread to Mysore, India, to parts of Latin America. But about 700 years ago, a group of well-meaning people petitioned Pope Vincent III and said, "This is truly the devil's drink and you need to ban it." And the Pope said, "Before I ban it, let me taste it." And when he tasted it, instead he baptized it, proclaiming, "Coffee is so good, the infidels should not have exclusive use of it." So what are the potential approaches to treatment in the future? Will likely include combination therapy and definitively lifestyle changes. This is a very interesting study in an experimental rat model of NASH, where combining angiotensin II receptor blockade with an oral iron chelator back to that increased iron attenuated progression of liver disease. Moderate exercise and coffee consumption likely of benefit. I tell my patients, go for a vigorous walk on a nice sunny day. You'll get your vitamin D, you'll get your exercise, and go to your favorite Java shop and get some coffee. A question that's asked every time I've given this talk. I have a patient with NAFLD. They have a mildly elevated ALT. I want to put them on a statin. Is it safe to use a statin? 2 studies now in gastroenterology and hepatology have shown that patients with fatty liver are not at higher risk for statin hepatotoxicity. So it's perfectly safe to use a statin in patients with underlying liver disease, as long as the liver disease is not cirrhosis with liver failure, where they would have such little hepatic reserve, and if you were unfortunate and got hepatotoxicity, it could be fatal. There is indeed a study showing that short-term statin use, and it's true for all of the statins, short-term statin use, any of the statins, but not other cholesterol-lowering agents like cholestyramine, actually lead to a 40% reduction in developing primary hepatocellular carcinoma. So not only is it safe, it's maybe something we should be prescribing to patients at risk for primary hepatocellular carcinoma. I'm going to conclude a little early with a quiz, and I want you, even if you're sitting alone in front of your computer, to answer the question loudly. So answer true or false. Number one, NAFLD is the most common hepatic disorder in the United States. So the answer is true. Number two, serum ferritin is elevated in 50% of patients with NASH. The answer is true. Three, NASH has been reported in children. I didn't address this during the talk, but we actually have 15-year-old patients at Children's Hospital, 18-year-old patients at Children's Hospital with NASH and cirrhosis heading for a liver transplant. They don't have Wilson's, they don't have maternal or vertical transmission of hepatitis B or alpha-1 antitrypsin deficiency. They have NASH with cirrhosis and liver failure. Number four, progression to cirrhosis occurs in 15 to 20% of patients. The answer is true. Number five, NASH is likely the leading cause of cryptogenic cirrhosis. And again, the answer is true. You may have seen a theme by now. All of them are true. So the next three are true as well. The histological features of NASH may be seen in patients with Wilson's disease. Both amiodarone and tamoxifen can cause NASH. Primary hepatocellular carcinoma has been reported in patients with NASH and cirrhosis. So all of these are true. You know, repetition is very good for adult learning. In the trade, we sometimes refer to it as optimal redundancy. Thank you very much for your attention.
Thank you, Sanjeev. We have some questions from our viewers. I'd like to start with this one from Dr. Picardo from Puerto Rico. He states the incidence of diabetes and obesity is growing continuously, but not every patient develops NASH. How can we tell which patients are going to develop NASH and subsequent cirrhosis?
So that's a terrific question. Thank you for that wonderful question. I don't think at the moment we can answer that question conclusively because there is no study looking at patients with obesity and diabetes, doing baseline liver biopsies and then following them prospectively and doing biopsies down the road to see which of those patients would have developed significant liver disease and progressed to cirrhosis. What I would say to you is stare at that ALT. And if it's high normal, they have liver disease. Consider a liver biopsy or a Fibro Scan. Take off the shirt if it's a man and examine them for palmaerythema and spider nevi and gynecomastia and testicular atrophy and look for splenomegaly. Stare at that platelet count. I had a patient whose platelet count was 240,000 and then slowly over 10 years it dropped to 110,000. That was the clue that he had advanced liver disease. Everything else was normal. Albumin, protein, bilirubin. You know, thrombopoietin is made in the liver. So it's not only the hypersplenism that occurs with portal hypertension that lowers the platelet count, it's also the advanced liver disease. So we tend to focus on the ALT and AST, but we need to look at the albumin. We need to look for splenomegaly, look for the platelet count, stare at that actual level of ALT.
Sanjay, we usually don't ask our patients how many grams of ethanol they're consuming,
right,
but rather either some equivalent of beer,
excellent.
wine.
Yeah, that's
so
a great question.
How do you translate
so
that?
the way to translate is, let's talk about 50 grams because I know the answer to that. So 50 grams of alcohol is 5.5 beers. 50 grams of alcohol is 3.5 glasses of wine. And 50 grams of alcohol is 1.6 stiff martinis. So it's not only that you're drinking alcohol, it's what alcohol are you drinking. And then remember to ask about the size of that wine glass. I actually have a slide I didn't show where there is a big wine glass and then there's a bottle of wine. And the glass of wine is full and I usually ask the question, well, how much of that wine bottle is in that glass? And is it 40%, 50%, or 60%? And since I'm asking it, when I'm giving this talk, most people say 60%, and the answer is 100%. So some of these glasses of wine take in a lot of wine.
We have another comment by Dr. Kimberly Beavers, who states that Fiberscan was approved by the FDA a few weeks ago, and we are just waiting for CPT codes to start using.
That is terrific news. Kimberly, I'm so grateful for you telling us this, because what I've been doing is I've been sending an email to my colleague Nid Aftal and Michael Curry every 3 or 4 weeks and asking, has it been approved? And they say, not yet, and I hadn't sent it recently. So thank you for knowing that, for telling us, sharing that information with us. I think the next question is, what will be the CPT code and will the insurance companies pay for it? And I think this is where the leadership in hepatology has to make a move. I think the American Association of Study of Liver Diseases, the Education Committee, the Policy Committee have to now start writing letters to the insurance companies.
Dr. Richard McNally asks, are non-obese people with metabolic syndrome at risk for NASH?
So I have seen a few such patients, and they actually are thin, they're physically fit, and on liver biopsy, they turn out they have mild elevations in ALT, AST, and I've done liver biopsies in these patients, usually only done the first liver biopsy, and they all turn out to have a little bit of macrovesicular fat infiltration. None of them had NASH. So they probably have some inherited disorder of lipoprotein metabolism in the liver. Many of these patients, in my experience, have turned out to be Korean or Chinese. And I don't know if that's a particular ethnic group we need to study more. But my current understanding and belief, and it's not based on evidence, is that they tend to have benign liver disease. They don't get cirrhosis of the liver.
Is there any relation between NASH and hepatitis C, from Dr. James Wilson?
So some patients with hepatitis C have increased fat in the liver, and it depends on the genotype, but they don't have NASH. Now, obesity is a risk factor for hepatic fibrosis progression in patients with chronic hepatitis C. So what is the most dominant risk factor for progression? Alcohol. But then after that, it's obesity. And then you may be surprised to hear marijuana smoking. So I focus on that. I grill my patients about alcohol, I calculate their BMI, and I also ask them about pot and marijuana. And they'll often say, what does that have to do with my hepatitis C? A very good study showed that it actually accelerates hepatic fibrosis.
Very good. Here's a question from Dr. Michael Nwude. He says some of us cannot handle coffee consumption because of receptor sensitivity. How can such people be made to tolerate coffee, considering its numerous benefits?
Yeah, so the numerous benefits I didn't mention earlier, but in addition to primary hepatocellular carcinoma, 40% reduction, 7 studies and a meta-analysis. In addition to primary hepatocellular carcinoma, low risk, in the last year and a half, 4 other cancers, low risk: metastatic prostate cancer, colon cancer, endometrial cancer, and skin cancer, melanoma, common cancers. And some the protection is 15%, some 20%, some 40%, but pretty dramatic. Tea, there's only one study that has shown protection in liver disease. So my patients who say, I don't like coffee, I just can't stand the taste, I've never been a coffee drinker, I encourage them to start with half a cup a day and see if they can slowly titrate it to 1.5 to 2 cups. A disclosure here, I happen to love coffee. I drink 4 or 5 cups a day. If I drink more, I will have insomnia. So you have to worry about insomnia, rare patients with palpitations, GERD, irritable bowel syndrome. It used to be said that pregnant women should not drink more than 1 cup of coffee a day. That's been challenged by the American College of Obstetrics and Gynecology, and they're not putting that limit anymore.
We have 2 questions about the same topic, really, the relationship between NASH and hepatitis C and or hepatitis B.
Right. So as I mentioned, in hepatitis C with a particular genotype, there is increased fat deposition in the liver, but it's not NASH. They have just fatty infiltration. And obesity, if they're obese, then they can have increased fibrosis. Hepatitis B, there isn't much good information, but there is no relationship of NASH due to hepatitis B virus itself.
Can someone be diagnosed with diabetes without having glycemia?
So that would be a better question for an endocrinologist or a diabetologist, but I don't think you can make the diagnosis of diabetes without either having a fasting blood sugar that's elevated, a 2-hour postprandial, rare circumstances, the glucose tolerance test is still done, or in fact there's a movement that people should measure the hemoglobin A1C to see if it's elevated. In the absence of that, I don't think one can make a definitive diagnosis of diabetes. You have to be hyperglycemic.
This will be our final question from Dr. Ida. Do you recommend vitamin E and rosiglitazone for a patient with chronic HCV and obesity with fatty liver?
No, I recommend weight loss. And again, vitamin E, we mentioned many of these patients who are obese have other risk factors for cardiovascular disease. And at 800 international units a day, there can be increased cardiovascular mortality. And as you saw from the study in the New England Journal of Medicine, that less than half the patients had some improvement in histology. Does it actually alter the natural history of the disease? We don't know. For the glitazones, I worry about the increased weight. If glitazone is going to be the best medicine to treat their diabetes, yeah, that's a good choice. Parenthetically, metformin has also been shown to improve patients with NASH. So I have a discussion with the diabetologist, and then we decide what medication the patient should be on.
Thank you. At this point, I would like to thank our sponsors, Shire, Viropharma Incorporated, UCB, and Ferring Pharmaceuticals, Inc., for their support of this important educational activity. Please remember to complete the quiz at the end of the session to secure your CME credits. And stay tuned for the next session, Rethinking Clostridium difficile. Thanks for joining us.
Good.